Welcome to today's session, which focuses on the technical demonstration of the infraneural approach for transforaminal injections, specifically in cases of lumbar discogenic pain. We have previously delved into various types of transforaminal injections and their indications. However, some practitioners still question each technique's specific details and suitability. So today, we'll zero in on the intricacies of the infraneural approach, illustrated by a recent case of discogenic pain, complemented by a technical video for hands-on understanding. Meet our patient. We are discussing a 43-year-old male with a VAS score of 8, complaining of right-sided lower lumbar, paraspinal, and gluteal pain. He has a history of surgical intervention at the L4-5 level for a herniated disc. He has been experiencing chronic tingling in his right lateral thigh, presumably due to a concurrent L5 nerve injury associated with herniated nucleus pulposus. Although he has been experiencing recurrent back pain, presumed discogenic due to the previously operated L4-5 level, he reported that this episode feels different from the past ones. Aggravating factors. The pain is exacerbated with positional changes, particularly when he bends forward. He could not stand straight due to pain, tilted to the left side, and could barely sit. He preferred to stand to lessen the discomfort during the history taking at the consultation room. MRI findings. A past laminectomy at right L4-5. An old black posterior annulus with low signal intensity at L4-5 means operation scar and remnant dehydrated posterior annulus with stabilized state. A new annular tear at L3-4 projected to the right inferior direction. Soft tissue disc extension at L3-4 moving inferiorly, with visible no protrusion or extrusion but impacting between the layer of the annular tear. If you watch the zoomed image, you can imagine the wedge expands the end of the peg and holds it firmly in place, and the stress of the torn annulus and pain. Clinical impression. We are drawn to the fresh annular tear at L3-4, which appears to be the root cause of his discogenic pain. This diagnosis guides our strategy for intervention. Interventional strategy. Delivering the medication to the torn annulus and surrounding inflammation is the goal of injectional interventional treatment. I opted for a transforaminal injection for this patient using the infraneural retrodiscal approach. The injection comprised 30 mg of triamcinolone, hypertonic dextrose solution, and 30 units of Botox. This targeted technique is aimed at the anterior surface of the torn annulus. Pain generation comes from three fundamental bases: structural derangement, chemical alteration, and neural ingrowth. So, I aim to change the chemical alteration of the environment and block the neural transmission of pain signals. The infraneural retrodiscal approach could offer more effective relief than the interlaminar epidural steroid or the subradicular approach of transforaminal injection, because I can focus on the injectant to the pathologic area. Sometimes, I directly infiltrate the medications into the disc for dramatic relief. C-arm guided infraneural retrodiscal approach. Our next segment will feature a step-by-step video demonstration detailing the procedure of the infraneural retrodiscal approach. I recommend reviewing the video multiple times to deepen your understanding of this method. An important distinction to note is between the infraneural and retrodiscal approaches. But the retrodiscal approach is a variant of the infraneural approach. Although the needle tip is placed in the same area, the direction of the injectant can vary based on the condition of the anterior epidural space. If it flows upward, it aligns more with the infraneural approach. If downward, it covers the anterior surface of the annular region, aligning with the retrodiscal approach. However, the needle tip is slightly lower in the retrodiscal approach than in the infraneural one. Let's watch the cinematic display of C-arm images, needle manipulation, and the injection process, all while adjusting the C-arm's rotation and tilt. The procedure begins with my radiologic tech aligning the vertebral end plate. This image is achieved by tilting the C-arm and obtaining a right ipsilateral oblique view. Even though the L3-4 annular tear is the primary cause of the discogenic pain in this case, I decided also to target the L4-5 annulus to be thorough. So, the first step is aiming for the right L4 infraneural approach. I initially approach with the needle held by long forceps. These placenta forceps give me more precise control and protect my hand from radiation as I navigate the needle through deep fascia and muscle layers. Once the needle path stabilizes, I hold it with my bare hand for better tactile feedback. You'll watch alternating between C-arm and needle views throughout the procedure to follow each step closely. To inject the contrast media, I use an extended mini-volume tube. This measure allows for better control and minimizes radiation exposure to my hand. Upon injecting the contrast, I observed it spreading more upward than anticipated. Even though I intended a retrodiscal injection, the contrast displayed more of an infraneural spread. Nonetheless, the therapeutic outcome between the two approaches is similar, so I wasn't particularly concerned. Then, I will move on to the right L3 infraneural retrodiscal approach, the real pain generator site. I will approach the needle in the same way. Enjoy the show. Thank you for joining us today. I hope this session enhances your technical proficiency in executing the infraneural retrodiscal approach for discogenic pain. Stay tuned for the next segment.